અને પ્રણામ. મારું નામ રાજવી પુનાતર છે અને OneJAIN અને Jain Health Initiative team તરફથી બધાને તમારું સ્વાગત કરું છું. આજે અમારી સાથે જોડાવા બદલ ખૂબ ખૂબ આભાર. આજનો વિષય છે મહિલા આરોગ્ય અને સશક્તિકરણ. તેના વિશે ઘણી બધી માહિતી આપવામાં આવશે અંગ્રેજી અને ગુજરાતીમાં. Hello everyone and welcome. My name is Rajvi Punathar. On behalf of OneJAIN and the Jain Health Initiative team, thank you very much for joining us today. Before we start our main program, I think for many of us it's been a difficult few days seeing the conflict that is happening in Europe, and lives are being lost and millions of people are being displaced. And I'm sure you join with us in just having a few moments of silence to pray for those people who are suffering right now. The subject of today's webinar is women's health and empowerment. And we're going to be tackling some topics today that many people find difficult to talk about. They might be embarrassed by them, or they're just traditionally taboo subjects. So they are infertility, the menopause, bladder weakness, and types of cancer screening, so cervical, breast, and bowel cancer. I would like to say that although we are calling this women's health, and of course it is to empower women, it is really, really important that the men in your lives understand the issues that you go through as well. So I'd like to ask if any of you are sitting by yourself and your menfolk are around in the house, please grab them and tell them to sit down next to you and watch as well. If they feel uncomfortable with that, or you do, then you can watch this video we are recording today. It will be available on the OneJAIN website for them to watch later on. But please do ask them to watch as well. We have 4 brilliant speakers today. So I'd like to introduce them one by one for you. First of all, we have Dr. Khyati Bakai. Khyati is a GP partner at Bromley by Bow Health. She's also a GP Connect director, and she's the primary care lead at Town Hamlets and the clinical lead for long-term conditions. Next, we will have Sunita Dhanani, who has 40 years of experience as a biomedical scientist in microbiology, and she's worked in a variety of hospital trusts, including at Northwick Park Hospital here in London. We also have with us Anuja Shah, who is a GP practicing in Luton, although she is London-based. She has 23 years of experience. She's also a trainer and educator of the next generation of GPs and a primary care network lead. She will be talking about the menopause. We have Shushma Shetna, who is a chartered physiotherapist working in both the NHS and private sector. And Shushma Ben is a lead physiotherapist for Sherwood clinics who are based in London and Essex. Shushma Ben is also a fantastic speaker in Gujarati, and she will be talking to us about bladder weakness. And we hope that by speaking in Gujarati and her slides are in English, that it will reach as many people as possible and benefit them. Now, while our panel are speaking, you may have questions that come to mind, and you can actually put them in the chat box at the bottom of your Zoom screen. If you are watching on YouTube, you can put them in the comments section. And if you wish to put your question anonymously, we will be putting links up where you can submit your question anonymously, and we won't see your name and no one else will, but we will still get the chance to put your questions to the panel. After all 4 of them have spoken, we will have a Q&A session moderated by Khyati Ben, and we hope to get through as many questions as possible then. So with that, I'd like to now hand over to Khyati Ben, who's going to start off with an introduction to infertility. Thank you.
Thank you, Rajvi Ben. I'm going to start this evening off with quite a difficult subject, which may be hard to listen to for lots of people: infertility. Before we start, I just want to warn people that it can be an emotional topic. We're going to hear a very personal story from Sunita Bin in a few moments as well. If you do find this upsetting, please do reach out, speak to people who you can trust, reach out to your doctors if you need to. And I've also left a link here for the British Infertility Counselling Association if you do want further help to talk about this. So infertility, what is it? Infertility is when a couple finds it difficult to get pregnant despite having regular unprotected sex. About 84% of people will conceive naturally within 1 year, but that leaves around 1 in 7 couples who may find it difficult. If you do not get pregnant after a year of trying, then it's important to go and see your GP because help can be available. If you are someone who knows that they might have trouble conceiving, or if you are around or over the age of 35, it's important to go sooner and perhaps not wait a year. There are some common known causes of infertility, both for men and for women, which is why when Rajvi said, if there are men around in your house, it's really important for them to listen, as often we find in the surgery that women come by themselves. But it's really important for both, if you can, to go and see the doctor together. Some common causes of infertility include polycystic ovarian syndrome, damage to your tubes inside, premature ovarian failure, which is when the ovaries stop working sooner than they ought to, and endometriosis, but there are many others. In men, the cause can be related to lack of sperm production, not having sperm that moves properly, or abnormal shape of the sperm. But in about 1 in 4 cases, a cause cannot be found, and that can be intensely frustrating for a couple who is already going through a stressful time. There are certain risks for infertility. We all know that as we get older, the chances of getting pregnant reduces with age. However, there are other causes, risks, which include being overweight or obese, smoking, drinking, having a history of sexually transmitted infections, and also stress, which can affect it in 2 ways. One, because it can have an effect on your sex drive. You don't feel like having sex if you're very stressed, or it can affect your egg production and your sperm production. So if you are having trouble getting pregnant, if you have had trouble getting pregnant, you go to the GP. What happens next? Well, the GP will take a full history, ask you about both your medical history and certain risks, which we can try and reverse if possible. And then there will be tests, blood tests, scan, sperm test, both for men and women. If there are any causes found which can be changed or addressed, the GP will help to address those, but there may then be an onward referral to a fertility clinic. In the fertility clinic, there'll be more questions and more tests to try and understand what the cause of not being able to conceive is. There will also be discussion of options available to support getting pregnant, and discussions of options of other ways to have a baby as well. All of this can be very time consuming and incredibly stressful. The impact of infertility is huge. Other than the emotions and the stress involved with this, it can have a huge impact on relationships. We know that lots of people who are having trouble conceiving, there can be marital problems or problems within the relationship with each other, but also problems with the wider family as well. It can have an impact on socializing. Lots of my patients tell me that they don't want to go to family weddings or family functions because people ask them, when are you going to get pregnant? When are you thinking of having a baby? And of course, it can have an impact on work as well. Having lots of tests, Having to go to appointments, having certain treatments can cause distractions and make you feel not able to work. And the impact is far more than this. So what can we do to support people who are going through this problem? Well, the reason we're talking about it today is because our community is not that good at talking about it. And we feel that starting a conversation will hopefully make people feel more comfortable to talk about it and make them not feel alone. What you can do if you're listening on the other end is listen without judgment. If you're going through this, think about joining a support group so you don't feel alone. And think about culturally how we make people feel around the subject of having babies. તમને બધાને ખબર હશે કે કોઈ લગન હમણાં લગન કઈ રહેશે અને તમે એને મળશો તો it's a common question કે હવે તમે good news ક્યારે આપો છો કે હવે બહુ રાહ નહીં જોતા, it's important to get pregnant soon. All these things, listening for someone who is struggling to get pregnant is incredibly upsetting and stressful. So as someone in the community, just consider the questions that you ask people around this. Again, I've put the link up for the British Infertility Counselling Association as another mean of support for these people. I'm going to stop now and pass you on to Sunita Bin, who's going to tell us a really personal story about her own journey with infertility. Thank you. Sunita Bin, over to you.
Jai, I'm going to talk about my personal experience with infertility. When we married, my husband and I were still studying, career ladder, mortgage, other responsibilities. So having children was the last thing on the list. A couple of years went by and our friends were having babies. They were talking about trying. So we decided, well, maybe it's time that we did. So we tried for a year and a half, but nothing happened. So then went to the GP to see what the course of action was. And he referred us to an infertility clinic just for investigations to see what was wrong. And it was on the NHS at the time. Anyway, I was poked, prodded, tested, cut up. I'm sure people who've been through it understand what I'm saying. I remember one moment when I was in hospital for one of these test procedures, and there was a woman in the opposite bed. And I struck a conversation and I said, why are you here? And she said to me, well, I've got 5 children. This is my 6th pregnancy. And I've actually come in for a termination because we can't afford any more children. See the irony of it? I'm sitting here thinking, why can't I have children? I do want children. And here is somebody who unfortunately can't afford to have any more. But that's life, isn't it? We've got to move on. Nothing we can do. Anyway, 5 years of all this. And the result was, there's nothing wrong with you or your husband. And at that moment, I thought, I wish there was something wrong. I could focus, hopefully there was treatment. But what do you do when somebody says, well, actually, there's nothing wrong with you? Again, to the GP and kind of said, what can we do about it? So he referred us on the National Health to an infertility treatment center. In those days, you had to be 35 or under to qualify. I did the quick maths. Obviously, I'd had 5 years of trying. And I thought, in 3 years' time, I'm actually going to be 35. And what if I miss that window? What happens then? So we decided we had some savings. So we'd go for private treatment. And we're talking about those days where there was no Google, no internet, no punching the button and the answer's there, hey presto. It was, again, go to the GP. And they weren't really quite fit to give that information. So what he did was just give me a few names of consultants, hospitals. So I actually phoned up people and luckily found a clinic that would take me on. And as the National Health had done everything they could for me, they just needed to actually treat me. So I had something called GIFT, G-I-F-T, gamete intrafallopian transfer. And that involves having hormones to actually produce more than one egg in a cycle. Then another injection at the right time, about 14 days, for the eggs to be released. Then the eggs are harvested. That means they're collected. And then they're graded. And then they're mixed with the husband's sperm. And then they port. So in my case, in those days, they put in 4. And the way they put it is transfer it straight to the fallopian tube. So there's more of a chance. And that was it. And it was like, okay, well, luckily, you know what? I got pregnant. And it was like, no, it wasn't a eureka moment. Because I'm sure people who've gone through it are going through it. You always hope, but you never get excited about these things. So I carried on my life. I had a senior position in the city. And I thought, well, that's fine. Time will come when I can concentrate. 28 weeks came, my maternity leave certificate. I was really excited because the next day I can concentrate on this baby. Went to the hospital, had the ultrasound, and the woman says to me, are you feeling okay today? And I said, yeah. Bloated? No. Oh, okay. Switched the ultrasound machine off and said, I'm going to consult a colleague. So there I was on my own, left. And then a few moments later, a head popped round the door, looked at me and said, you know, don't you? And yeah, I knew. Basically, the baby had actually died inside. So it's termed an intrauterine death, IUD. They phoned my husband. He came from work, sat us down and explained what the next procedure is. And basically, obviously, the baby had to come out. So it was either inducing me or having a cesarean. And I had decided at that moment, I'm not going to have a cesarean. I am not going to be cut up and not show anything for it. Anyway, we were told, go home, rest, come back in the morning at 7 o'clock. I had a very good friend who was a nurse at the time. She rang and said, I have to come and see you. And she advised me that when this baby is born, hold it, look at its face, spend some time with it. So after 3 days of being induced and God knows what, I actually gave birth. I remember the midwife at the time said, oh, do you want a photograph? And my husband and I looked at each other. I remember hormones, anger, sadness, all this is going on. And this woman saying, do you want a photograph? And we thought, well, who are we going to show this photograph to? And secondly, does it mean if I have a photograph, I'm going to sit there every day and look at it and the regret and everything just goes flooding back day by day? So we decided, no, not going to have a photograph because we're going to remember this moment for the rest of our lives. So went home, was there for 2 months, didn't go to work, watching daily television, and it went in, out, in one ear, out the other. It was fine until one day, the question was posed to this woman. So didn't you realize that the baby wasn't moving? I thought, wow, that's what these women who've been coming to, pass their condolences and also quiz me and say, "Tane khabar nati? Ke halti nati, baby?" And it was like, no, I didn't. I felt guilty. I was really guilty. I should have known. Anyway, there's this woman, and her story was she had 2 children, perfect pregnancies. The third one, she at full term, she gave birth to a stillborn. That's when I knew that other women go through it. And 2, it wasn't my fault. And it was also a positive from it that I could get pregnant. And at that time, she gave a telephone number of an association called SANS, which is Stillbirth and Neonatal Death Society. And I was so happy that, other women are going through this. I'm not alone. I rang them, spoke to a lovely woman and said, that they have support groups. I have people in my local community. I never took them on though, because I was now happy that whatever it was, nature took its course, but I can still get pregnant. So we had 2 more attempts at gift. Unfortunately, no success. I stepped down from my role, tried to get a part-time job at a local hospital, which I did. And there I heard that this doctor is doing some research on infertility. So I went to my GP and said, refer me. He said, oh, why would he take you on? I said, just send it. Then, I'll sort it out. Anyway, I got an appointment. I walked into the office and guess what? This was the same doctor 2 years earlier who had told me that my baby had died. Obviously, he didn't remember because unfortunately, he had to tell this news to so many women. So he accepted me because I had become pregnant before. And he, for a fraction of a price, a donation, he did what he called was an intrauterine transfer. So basically the same thing as before, but he injects it in a different place. He said, okay, come back tomorrow morning too, because there's some eggs that haven't been released, and we'll do it again with your husband's sperm. I thought, okay. Unfortunately, the next day I bled for an hour. I had to lie there until the bleeding stopped. And of course, anybody out there who's been through things like this, it's like, well, hey, that's the end. But I have a very happy ending. I actually gave birth prematurely, about 30 plus weeks. They were in special care, but twins, a boy and a girl. And people ask me, what would you have changed? And you know what? After having 2 beautiful children, what can you change? Obviously, I do not want myself or anybody to go through losing a baby, but there's a positive at the end. Whatever you're going through, there's always another way. So I hope my story makes you feel that you can actually talk about it, that there are people out there. And if it happened to it 30 years ago, so what? My emotion is still rife. So hopefully it'll at least help one person out there. JT.
Thank you, Sunita Bin. I'm sure that, firstly, I just want to say a huge thank you to Sunita Bin. I'm not sure that I've ever heard anyone tell such a personal and difficult story so honestly and openly. And we are so grateful that you're leading the way in helping our community talk about this more. So thank you, Sunita Bin, on behalf of all of us. Again, to everyone in the community listening, if you are upset or emotional listening to any of this, please do reach out for help. We've posted some links in our chat as well, and we're here to support you. So please don't feel that you're alone when talking about this difficult topic. Moving on from one difficult topic to another equally important area that we don't talk about very often, I'd like to pass you on to Dr. Anujabin Shah, who's going to talk to us about the menopause. Thank you, Anujabin.
Thank you, Kathy Ben, and thank you, Sunita Ben, for that really insightful description of what you went through. Just going to share my screen. So my name is Anuja Shah. I'm a GP, and today let's talk about the menopause. So why should we talk about the menopause? Surely, menopause has been around for as long as women have been around. And, what's new? But the demography has changed. 100 years ago, women went through the menopause at 57 in the UK. And the lifespan of women in those days was 59 or 60. So women were living with the menopause for only a few years, maybe 2 to 5 years. But now, women in the UK are going through the menopause at the average age of 51. And the lifespan of women these days is 81. So we're living with the menopause for 30 years or more. Moreover, 8 out of 10 menopausal women are still working. So menopausal women make a very large proportion of the workforce. So surely it is an important topic to talk about, isn't it? I don't think it should be a taboo subject anymore, and we should talk about the difficulties that women face in the workplace in particular more and more. સ્ત્રીઓ મેનોપોઝની સમસ્યાથી ઘણો લાંબો સમય સુધી જીવે છે, એટલે આ વિષય ઉપર આપણે ચર્ચા કરવી ખૂબ જ જરૂરી છે. So what is the menopause? Menopause basically marks the end of the menstrual cycle. And we can only say that someone is menopausal after about 12 months of their last period. So if they've had no periods for 12 months, that's when we can say that they're menopausal. As I said, the average age of the menopause in the UK is 51, but you can expect to have menopause between the ages of 45 and 55, or even earlier. 1% of women go through the menopause before the age of 40. This is what is called as premature menopause. So menopause, coming towards the menopause, is a gradual process, and it's called the perimenopause. This is when the transition takes place and your hormones, the estrogen and progesterone, are either leaving or have left the building. And this lack of these hormones make your periods infrequent and give you all the symptoms of the menopause. This transitional period called the perimenopause can last for 4 to 8 years or even longer. Menopause samasya period સમાપ્ત થાય એના પહેલાથી શરૂ થઈ શકે છે, અને જે લક્ષણો છે એ ઘણા વર્ષો સુધી 4 થી 8 વર્ષ સુધી રહી શકે છે. So what are the symptoms of the menopause? We're all aware of the symptoms of hot flushes, and 3 out of 4 women actually go through this problem. 1 out of 4 women go through severe problems with hot flushes. This is mainly due to the lack of the hormone estrogen. Night sweats and problem sleeping. Sleeping problem is not just because of the snoring husband or partner, but actually due to the lack of the calming hormone called progesterone. Headaches, tiredness, aches and pains, memory problems. This can be quite common as well, and women often describe this as brain fog. Mood changes and anxiety, low moods, tearfulness, and feeling just very anxious is also very common. And often women put it down to other life events, such as children leaving home, or elderly parents, or ill parents, or parents that have died recently, or problems with relationship or work stresses, palpitations. Urine infections and urine problems are also very common. And Shushma Ben is going to tell us a little bit more about this in her talk. These are just some of the symptoms. And in total, there are more than 34 symptoms of the menopause. The menopause na ઘણા બધા લક્ષણો હોય છે, અને એમાં hot flushes and night sweats ખૂબ જ સામાન્ય છે. There are some long-term problems or effects of the menopause. Thinning of the hair and skin is very common. Vaginal dryness, which can cause vaginal soreness and irritation and itching, is also very common and can come many years after the menopause. But more worryingly, it is the thinning of bones. The lack of estrogen can cause the bones to thin and become brittle, causing osteoporosis, which can later lead to fractured bones, in particularly the hip and the spine. So this can be a very worrying effect of the menopause. Cardiovascular disease, again, the lack of estrogen can cause us to have increased risk of heart problems, such as heart attack. લાંબે ગાળે મેનોપોઝના લીધે આપણા હાડકા નબળા પડી શકે છે અને આપણને હૃદયની બીમારી જેમ કે હાર્ટ અટેક થઈ શકે છે. So a test is not generally needed if you are over the age of 45 and if you have some of the symptoms. But if you are younger than 45, then your GP might suggest that you have some blood tests to rule out other causes of your symptoms. Usually the tests are not very reliable as the hormones fluctuate and you may not catch them at its peak or whatever. So they're not very reliable. Blood test ની જરૂર નથી રહેતી. જો તમને મેનોપોઝના લક્ષણો હોય છે અને તમારી ઉંમર 45 yearsથી ઉપર હોય છે તો બ્લડ ટેસ્ટની જરૂર નથી પડતી. So what can we do to help ourselves? Exercise is very important. Exercise not only helps with the symptoms of hot sweats and night sweats and hot flushes, but it will improve sleep and it will improve your mood as well. Weight-bearing exercise, which means any exercise which is against the resistance of gravity, such as walking or jogging or dancing or hiking, are very good for your bone health and actually improve the bone health. Yoga and Pilates are very good for muscle strength, and they also improve your sleep and improve mood. Meditation will also help with that. Maintain a healthy weight. We know that around the menopause or just after the menopause, women tend to put on weight. This is because our metabolisms can slow down and we lose some muscle mass. So we don't need as many calories as we did when we were younger. So try and maintain a healthy weight by having a balance between calories that you consume and the amount of exercise you do. Cognitive behavioral therapy is another fantastic way to help with mood changes and some of the symptoms of menopause. Some practical help, such as keeping cool, wearing cotton clothes, having a fan, opening your windows, particularly at your workplace, will help with some of your symptoms. Stopping smoking, reducing alcohol intake, and reducing spicy food and caffeine also tends to help. And good news is that bitter dark chocolate will help with some of the symptoms of menopause. So, have dark chocolate. Vitamin D and calcium, as well as magnesium, will also help with bone health. કસરત અને સ્વસ્થ આહારથી તમને મેનોપોઝના ઘણા બધા લક્ષણો અને તકલીફોથી રાહત મળે છે અને તમારા હાડકા મજબૂત બની શકે છે. So what is the treatment for menopause? Your GP may suggest or even recommend HRT. HRT is actually recommended in women who are young and are going through the menopause, as HRT will prevent the osteoporosis and the cardiovascular effects of the menopause. HRT is a very effective treatment for hot flushes and night sweats. Your GP may also suggest some other treatment for vaginal dryness. તમારા ડોક્ટર તમને HRT એટલે કે હોર્મોન રિપ્લેસમેન્ટ થેરપી વિશે તમારી સાથે ચર્ચા કરશે. અને ઘણી વખત જો તમારી ઉંમર નાની હોય તો HRT બહુ જરૂરી થઈ જાય છે. But you must tell your doctor if you've had any bleeding after not having a period for a year, or if you have any bleeding in between periods, or if your periods have become unusually heavier. These can be serious and can mean something more sinister than just the menopause. Some very useful resources for menopause are Menopause Matters, where you can read all about the different symptoms of menopause and how you can help yourself. Patient Info can also give you a lot of information about the menopause. And Daisy Network is particularly useful for people who are going through an early or premature menopause. So let's make a change about the way we look at the change. Let's talk to family and friends. Let's talk to our partners and our husbands, and let's help them to understand what we're going through and what the menopause is. Let's encourage employers to improve their workplace environment. Let's talk to our male colleagues at work and tell them what we're going through. Let's make it a different place for our future generations, for our daughters, so they don't have to go through what we've gone through. Let's make the change. Thank you. I'll pass it on to Shushma Ben now. Thank you.
Sharing my screen. સર્વે વડીલો અને મિત્રોને મારા પ્રણામ. વિમેન્સ હેલ્થ અને એમ્પાવરમેન્ટ જૈન હેલ્થ ઇનિશિયેટિવે આજે જે સંવેદનશીલ વાત આપણી સાથે છેડી છે, તો એ શૃંખલાની આગળની કડી હવે હું લઈશ. જે રીતે ખ્યાતિબેન, સુનીતાબેન ઇન્ફર્ટિલિટીની વાત કરી અને અનુજાબેને આપણે મેનોપોઝની વાત કરી, આ એવા સંવેદનશીલ સેન્સિટિવ વિષયો છે. એ જ રીતે બીજો એક એવો વિષય છે બ્લેડર વીકનેસ, એટલે કે મૂત્રાશયની નબળાઈ. મારું નામ સુષ્મા શેટના છે અને હું ફિઝિયોથેરાપી પ્રેક્ટિશનર છું. પેલ્વિક હેલ્થ અને પેલ્વિક ફ્લોર રિહેબિલિટેશન મારા ખાસ રસનો વિષય છે. તો બ્લેડર વીકનેસ એટલે કે મૂત્રાશયની નબળાઈ સ્ત્રીના જીવનમાં ક્યારે પણ આવી શકે છે, નાની ઉંમરે કે મોટી ઉંમરે. તો આજે આપણે એના થોડા કારણો વિશે થોડી માહિતી મેળવશું અને ખાસ કરીને આપણે પોતે આ તકલીફમાં કઈ રીતે અસરકારક રીતે એનો ઇલાજ કરી શકીએ એ વિશે પણ જાણીશું. તો વોટ ઇઝ બ્લેડર વીકનેસ, અથવા તો આપણે કહી શકીએ યુરિનરી ઇન્કોન્ટિનન્સ, એટલે કે તમારો પેશાબ કરવાની પ્રક્રિયામાં કાબુનો અભાવ. સો જ્યારે એક સાધારણ પ્રક્રિયા હોય છે કે આપણું યુરિન જે રીતે આપણા મૂત્રાશયમાં સ્ટોર થાય છે અને એમાં આપણે જે રીતે યુરિન પસાર કરીએ છીએ, પેશાબ પસાર કરીએ છીએ, એ જે પ્રોસેસ છે એમાં ક્યાંક ખામી આવી જાય, ક્યાંક અટકાવ આવી જાય. સો ધેટ ઇઝ યુરિનરી ઇન્કોન્ટિનન્સ. આ એક લક્ષણ છે. ઇટ્સ અ સિમ્પટમ, ઇટ્સ નોટ અ ડાયગ્નોસિસ. એટલે કોઈ કન્ડિશન નથી, કોઈ બીમારી નથી, એક ચિહ્ન છે. અને લાંબા ગાળાનું પણ હોઈ શકે કે ટૂંકા ગાળા માટે પણ થઈ શકે. અને આપણે જો એનું કારણ જાણી શકીએ, if we know the cause, then we can treat, even cure the incontinence. તો કયા ટૂંકા અને લાંબા ગાળાના ઇન્કોન્ટિનન્સના કારણો છે? આપણે જાણીએ છીએ કે પ્રેગ્નન્સી. તો જ્યારે પ્રેગ્નન્સીમાં ઘણીવાર બહેનોને આ તકલીફ થતી હોય છે કે વારંવાર જવું પડે અને ઘણીવાર એમ થાય કે there is a little leakage, just a drop or two એમ લીક થાય. અને પોસ્ટનેટલ ચાઇલ્ડ બર્થ પછી પણ ઘણીવાર આ તકલીફ ચાલુ રહી શકે છે અને ધીરે ધીરે પછી એમાં કદાચ હોર્મોન્સના પરિવર્તનને કારણે પાછું સરખું પણ થઈ શકે છે. પણ women experience this during pregnancy and postnatally at times. એ જ રીતે પોસ્ટ સર્જિકલ ઇન્કોન્ટિનન્સ એટલે કોઈ તમે ઓપરેશન કરાવ્યું હોય, દાખલા તરીકે હિસ્ટેરેક્ટમી કે પુરુષોમાં પણ પ્રોસ્ટેક્ટમી. એન્ડ આઈ મેન્શન ધીસ કારણ કે હું આશા રાખું છું કે ભાઈઓ પણ આ કાર્યક્રમ જોતા જ હશે. અને ઇન્કોન્ટિનન્સ સ્ત્રી અને પુરુષ બંનેને અસર કરી શકે છે. સો it can happen to men as well after a surgery like prostatectomy. તે ઉપરાંત પોલિન્યુરોપેથી એટલે કે નર્વ્સ પર કોઈ અસર થઈ હોય, ખાસ કરીને વિટામિન B12 ડેફિશિયન્સી થઈ હોય, તો એ વખતે ટૂંકા ગાળા માટે આપણે આ યુરિનરી ઇન્કોન્ટિનન્સ અને આપણા બ્લેડરમાં નબળાઈ આવી શકે છે. લાંબા ગાળાના કારણો કયા કયા છે? સો સ્પાઇનલ કોડ એટલે કે કરોડરજ્જુમાં કોઈ તકલીફ થઈ હોય, એમાં કોઈ બીમારી હોય, એને કારણે બ્રેઇનમાંથી સ્પાઇનલ કોડ દ્વારા આપણા મૂત્રાશયમાં સંદેશા બરાબર પસાર થઈ શકતા નથી અને એને કારણે તમને તકલીફ થઈ શકે છે, લીક થઈ શકે છે. બીજી ન્યુરોલોજીકલ બીમારીઓ જેવી કે સ્ટ્રોક, મલ્ટિપલ સ્ક્લેરોસિસ કે બીજી સ્પાઇનલ કોડની કોઈ પણ પેથોલોજી કે કોઈ પણ કન્ડિશન હોય તો એને કારણે પણ લાંબા ગાળાની ઇન્કોન્ટિનન્સનો આપણે સામનો કરવો પડે. હવે આ ઇમેજમાં આપણે જોઈએ કે આપણા પેલ્વિસ અને એના અંદરના સ્ટ્રક્ચર્સ કયા કયા છે. તો આ ચિત્રમાં આપણે જોઈ શકીએ છીએ કે સૌથી પાછળનો ભાગ છે એ સ્પાઇન છે અને એની પછી તરત જ જે આ દેખાય છે that's your large bowel or મોટું આંતરડું અને એની આગળ આવ્યું છે ગર્ભાશય, યુટ્રસ, અને યુટ્રસની આગળ છે મૂત્રાશય અથવા તો બ્લેડર, યુરિનરી બ્લેડર. હવે તમે અહીંયા જોશો કે આ જે નાનકડું હેમક અથવા તો લાઈક પારણા જેવું, સ્લિંગ જેવું આ ભાગ છે એ આપણા પેલ્વિક ફ્લોર મસલ્સ છે. એન્ડ થ્રુ ધેટ મસલ્સ યુ કેન સી કે આ લાર્જ બાવલનું જે ઓપનિંગ છે એટલે કે બેક પેસેજ અહીંયા ખુલે છે, એની આગળ છે આપણું ગર્ભાશયનું ઓપનિંગ એટલે કે વજાઇનલ ઓપનિંગ અને એની પણ આગળ છે યોર બ્લેડર ઓપનિંગ જેમાંથી મૂત્ર પસાર થાય છે. એટલે યુ કેન સી કે આ પેલ્વિક ફ્લોર મસલ્સ દ્વારા આ ત્રણેય ઓપનિંગ આપણા શરીરમાંથી ખુલે છે, 3 દ્વાર. ઓકે, સો સ્ટ્રેસ ઇન્કોન્ટિનન્સ એક આ વીકનેસનો એક પ્રકાર છે, બ્લેડર વીકનેસનો સ્ટ્રેસ ઇન્કોન્ટિનન્સ. અહીંયા સ્ટ્રેસ એટલે માનસિક તણાવ નહીં પણ દબાણ, પ્રેશરને કારણે પેશાબનું ટપકવું, લીક થવું કે ગળવું. તમારા બ્લેડર ઉપર, મૂત્રાશય ઉપર ઓચિંતું ખૂબ દબાણ આવી જાય, દાખલા તરીકે તમને ખૂબ ઉધરસ આવે અને એને કારણે તમને થોડું લીક થાય, થોડેક ટીપા યુરિન ટપકે. અને બીજી પણ ઘણી એવી એક્ટિવિટી આપણે થઈ શકે ઓચિંતી જેને કારણે આપણને યુરિનની લીક થઈ શકે, દાખલા તરીકે છીંક આવવી અથવા તો જોરદાર એકદમ હસવું આવવું. કોઈક વાર તમે કોઈક વાંકા વળી અને વજન ઉચકતા હો તો એ વજન ઉચકવાને કારણે તમને ઓચિંતી એમ થાય કે થોડું યુરિન લીક થયું છે. હેવી એક્સરસાઇઝ, હિટ એક્સરસાઇઝ, હાઈ ઇમ્પેક્ટ એક્સરસાઇઝને કારણે પણ લીક થઈ શકે. અને આ લીક ઘણીવાર નાનકડી થોડી હોઈ શકે પણ જો if your bladder is full અને તમે ન ગયા હો તો ઘણીવાર ઘણું બધું લીક પણ થઈ શકે. હવે બીજો પ્રકાર છે ઇન્કોન્ટિનન્સનો અથવા બ્લેડર વીકનેસનો, અર્જ ઇન્કોન્ટિનન્સ. અર્જ અથવા તો અર્જન્સી એટલે કે શું કે તમને જવાની ઈચ્છા થાય અને એ ઈચ્છાને પછી તમે કાબુમાં જ રોકી ના શકો, તમારે તરત જ ટોયલેટ જવું પડે અને ટુ પાસ યુરિન, કારણ કે યુ કેન નોટ કંટ્રોલ ઇટ એનીમોર. એટલે urgency incontinence, sudden and very intense need to pass urine and you are unable to delay going to the toilet. હવે એના ટ્રિગર્સ કયા કયા છે, કઈ રીતે આ થઈ શકે છે? તો ઘણી જુદી જુદી રીતે આપણને અર્જ ઇન્કોન્ટિનન્સ થઈ શકે. દાખલા તરીકે જો આ તકલીફ આપણને હોય તો ફક્ત તમે if the tap is on, ખાલી પાણીનો નળ ચાલુ કર્યો હોય એની સાથે જ તમને ઈચ્છા થાય કે મારે જવું પડશે, અથવા તો તમે બાથરૂમ આગળથી પસાર થતા હો અને તમને ખબર હોય કે આ બાથરૂમ છે અને યુ પાસિંગ બાય એન્ડ ધેન યુ સડનલી ફીલ ધ અર્જ ટુ ગો. સમટાઇમ્સ even during sex you can have a sudden urge and that can be of course a very embarrassing experience. ઘણીવાર તમે પોઝિશન સુવામાં બદલો કે સાઈડ ઉપર પડખું ફરો અને તમને એકદમ અર્જ થાય કે જવું પડશે. એટલે those can be the potential triggers. અને ઘણીવાર આ બધી જે ચિહ્નો છે, આ બધા લક્ષણો છે એ ઓવર એક્ટિવ બ્લેડર સિન્ડ્રોમ કરીને એક કન્ડિશન આપણે કહી શકીએ અથવા તો ગ્રુપ ઓફ સિમ્પટમ્સ, એને કારણે આ બધા આપણને લક્ષણો થઈ શકે છે અને એમાં આપણા જે મૂત્રાશયનો સ્નાયુ છે બ્લેડર મસલ એ વધારે પડતો એક્ટિવ હોય એને કારણે થાય છે. અને વોટ ધેટ મીન્સ ઇઝ કે તમારે અવારનવાર જવું પડે, ખાસ કરીને રાત્રે પણ ઓવર એક્ટિવ બ્લેડરને કારણે વધારે જવું પડતું હોય છે. ઘણીવાર બહેનોને આ બંને પ્રકારની નબળાઈ હોઈ શકે છે. મિક્સ્ડ ઇન્કોન્ટિનન્સ એટલે સ્ટ્રેસ, દબાણથી થઈ શકે અને અર્જ પણ થઈ શકે. એટલે તમે ઉધરસ આવે કે તમે છીંક આવે અથવા તો તમને એકદમ અર્જ, ઇન્ટેન્સ અર્જ થાય, ઉત્તેજના, તમારે જવું પડે. ઓવરફ્લો ઇન્કોન્ટિનન્સ આ એક ત્રીજો પ્રકાર છે, એટલે કે ઉભરાવું, ઓવરફ્લો. વોટ ડઝ ધેટ મીન? એટલે ઘણીવાર એવું બને છે કે મૂત્રાશયના જે સ્નાયુઓ હોય છે તે એમાં કોઈ જાતનું દબાણ હોય કે ઓબ્સ્ટ્રક્શન હોય એને કારણે થોડા નબળા પડી ગયા હોય છે અને થોડું ફૂલી ગયું હોય છે. એને કારણે કોન્સ્ટન્ટલી એ તમને અર્જ થયા કરે, તમારે જવું જ પડે. અને જ્યારે તમે બાથરૂમ જાઓ, પેશાબ કરવા જાઓ, ત્યારે પૂરેપૂરું તમે બ્લેડરને ખાલી, મૂત્રાશય પૂરેપૂરું એમ્પ્ટી થઈ શકતું નથી. એન્ડ યુ ફીલ કે there is still something that you need to still go again. એટલે that is overflow incontinence. હવે આ ચિત્રમાં તમે જોશો કે સ્ટ્રેસ ઇન્કોન્ટિનન્સ એટલે કે તમારા સ્નાયુઓ નબળા છે, પેલ્વિક ફ્લોરના, પેડુના સ્નાયુઓ, અને એને કારણે થોડુંક લીક થાય છે. અર્જ ઇન્કોન્ટિનન્સ એટલે ઉત્તેજનાને કારણે જે ઇન્કોન્ટિનન્સ થાય છે એમાં વધારે પડતા સ્નાયુની એક્ટિવિટી, ઇટ્સ ઓવર એક્ટિવ, એને કારણે તમને અહીંયા લીક થયા કરે છે. જ્યારે ઓવરફ્લોમાં મૂત્રાશયના સ્નાયુમાં તાકાત જ નથી હોતી, એને કારણે ઇટ કીપ્સ લીકિંગ, ઇટ જસ્ટ કેનોટ હોલ્ડ એનીમોર. હવે કોઝિસ ઓફ સ્ટ્રેસ ઇન્કોન્ટિનન્સ, પેલી દબાણની આપણે જે વાત કરી એના કારણો કયા કયા છે? સીધી વાત છે કે મસલ્સ એટલે કે સ્નાયુમાં તાકાત ઓછી હોય અને દબાણ વધારે હોય તો there is a leak. આપણે જેમ કહ્યું એમ હસવું, ઉધરસ આવવી, છીંક આવવી, વાંકા વળીને અથવા વધારે હેવી વજન ઉચકવું કે કોઈ જાતની હેવી ઇમ્પેક્ટ એક્સરસાઇઝ કરવી, આ બધા કારણોસર સ્ટ્રેસ ઇન્કોન્ટિનન્સ થઈ શકે છે. આપણે એની વિશે થોડી વધારે વાત કરીશું. બીજું એક વસ્તુ એ છે કે જ્યાંથી યુરિન પસાર થાય છે એ ભાગ, એ દ્વાર છે, ત્યાં ઘણીવાર સ્નાયુઓની નબળાઈને કારણે એમાં પણ વીકનેસ આવી ગઈ હોય છે અને કોઈક વાર ડેમેજ પણ થઈ શકે છે, ઘણીવાર પ્રેગ્નન્સી અથવા તો વેજાઇનલ ડિલિવરીમાં, અને એને કારણે પણ ઇન્કોન્ટિનન્સ થઈ શકે છે. પ્રેગ્નન્સી અને ચાઇલ્ડબર્થ જે આપણે હમણાં જ કહ્યું એને કારણે થાય. મેનોપોઝ, જે અનુજાબેને આપણને વાત કરી, તો મેનોપોઝને કારણે હોર્મોન્સની આપણા શરીરમાં જે પરિવર્તન આવે છે એને કારણે સ્નાયુઓ પણ નબળા પડે, ઇસ્ટ્રોજન પણ ઓછું થતું જાય અને એને કારણે થોડી ઇન્કોન્ટિનન્સ થવાના શક્યતા વધે છે. એજિંગ, ઉંમરને કારણે જેમ બધા જ સ્નાયુઓ શરીરના નબળા પડે તો પેલ્વિક ફ્લોર ઇઝ નો એક્સેપ્શન ટુ ધેટ આઈધર, એટલે એને કારણે પણ નબળાઈ આવવાથી આ તકલીફ ઊભી થાય છે. કોઈ જાતનું ઓપરેશન કરાવ્યું હોય, તે ઉપરાંત હેરિડિટરી ફેક્ટર્સ, આપણા મમ્મીને, દાદીને જો આ તકલીફ હોય, તમે જાણતા હો અને કદાચ એને કારણે તમને પણ થવાના ચાન્સીસ હોય. તે ઉપરાંત સોફ્ટ ટિશ્યુ કન્ડિશન્સ, દાખલા તરીકે હાઇપર મોબિલિટી સિન્ડ્રોમ, જેમાં મસલ્સ કે સ્નાયુઓ ખૂબ જ વધારે પડતા ફ્લેક્સિબલ હોય, એને કારણે પણ એ નબળા પડે, એનો ટોન ઓછો થાય અને ધેટ કેન લીડ ટુ સ્ટ્રેસ ઇન્કોન્ટિનન્સ. અને જેમ આપણે પહેલા કહ્યું, ન્યુરોલોજીકલ ડિસઓર્ડર્સ. લાઇફસ્ટાઇલ, હવે આ વસ્તુ ખૂબ મહત્વની છે. દાખલા તરીકે મેન્યુઅલ વર્ક, તમે એવું કોઈ કામ કરતા હો જેમાં અવારનવાર તમારે વજન ઉચકવાનું આવે, તમારું ખોરાક એવો હોય જેનાથી તમને કોન્સ્ટિપેશન થાય, તમારું વજન ખૂબ વધારે હોય અને તમે સ્મોકિંગ કરતા હો, તો આ બધું જ એને કારણે સ્ટ્રેસ ઇન્કોન્ટિનન્સ થવાના ચાન્સીસ ઘણા વધે છે. અર્જ અને ઓવરફ્લો ઇન્કોન્ટિનન્સ, આપણે જેમ કહ્યું બ્લેડર, મૂત્રાશય વધારે પડતું એક્ટિવ હોય છે, ત્યાં કોઈ જાતનું ઓબ્સ્ટ્રક્શન હોય, એમાં કોઈ આગળ દબાણ હોય જેથી યુરિન સહેલાઈથી પસાર થઈ શકતું નથી, પૂરેપૂરું ખાલી થઈ શકતું નથી. હવે એક્સેસિવ આલ્કોહોલ કે અમુક એવા પીણા આપણે લઈએ, દાખલા તરીકે ટી અને કોફી, એમાં કેફીન છે, એ જ રીતે સોફ્ટ ડ્રિંક્સ અને આલ્કોહોલ, વાઇન, કંઈ પણ તમે એવા કેફિનેટેડ ડ્રિંક્સ લેતા હો જે તમારા બ્લેડરને વધારે સ્ટિમ્યુલેટ કરે અને એને કારણે તમારે વધારે જવું પડે. બીજું કે તમે પ્રવાહી આખા દિવસમાં તમારું ફ્લુઇડ ઇન્ટેક બહુ ઓછો હોય, એને કારણે ધ યુરિન બીકમ્સ મચ સ્ટ્રોંગર, કોન્સન્ટ્રેટેડ, અને એને કારણે ધેટ ઇરિટેટ્સ ધ બ્લેડર અને એને કારણે બ્લેડર બીકમ્સ ઓવર એક્ટિવ. કોન્સ્ટિપેશન, તમે કબજિયાતની તકલીફ હોય ઘણા વખતથી, તો એને કારણે પણ બ્લેડર, જેમ આપણે પહેલા પિક્ચરમાં જોયું કે how bowel, the uterus and the bladder are one behind the other, એના દબાણને કારણે બ્લેડર ઉપર પણ અસર થઈ શકે છે. અને તે ઉપરાંત અવારનવાર જો યુરિનરી ટ્રેક્ટ ઇન્ફેક્શન્સ થતા હોય કે બ્લેડરની બીજી કોઈ સિરિયસ ગંભીર બીમારી હોય એઝ ઇન ટ્યુમર્સ, તો એ દબાણને કારણે પણ અર્જ અને ઓવરફ્લો ઇન્કોન્ટિનન્સ થાય. ન્યુરોલોજિકલ કન્ડિશન્સ અને અમુક દવાઓ એઝ ઇન્હિબિટર્સ કે બીજી અનેક દવાઓ હોય છે, ડાયુરેટિક્સ ઇવન, એને કારણે પણ આ અર્જ અને ઓવરફ્લો ઇન્કોન્ટિનન્સ થઈ શકે છે. તો આ બધી તકલીફો આપણે જાણી કે આ ઇન્કોન્ટિનન્સની છે, આપણને આ તકલીફ છે, તો એમાં સંકોચાવાની કોઈ જરૂર નથી. તકલીફ છે તો એના વિશે વાત કરી અને એના વિશે આપણે શું કરી શકીએ એના માટે તમારા ડોક્ટરને, તમારા જીપીને મળવું ખાસ જરૂરી છે. અને એ તમે એમને મળો ત્યારે એ તમને કહી શકે કે આ ત્રણ આપણે જે વાત કરી, સ્ટ્રેસ, અર્જ કે ઓવરફ્લો, એમાંથી કઈ જાતની ઇન્કોન્ટિનન્સ તમને છે અને એનો ઈલાજ એ તમને બતાવી શકે. એટલે તમને સવાલો પૂછશે તમારા ડોક્ટર કે તમે ઉધરસ આવે છે કે તમે હસો કે વજન ઉચકો છો ત્યારે તમને ઇન્કોન્ટિનન્સ થાય છે, તમારે અવારનવાર ખાસ કરીને દિવસે રાત્રે વધારે વાર જવું પડે છે, કે તમને કોઈ તકલીફ છે, દુખાવો છે યુરિન પાસ કરતી વખતે, અથવા તો પૂરેપૂરું તમે ખાલી ફીલિંગ થાય છે કે પૂરેપૂરું યુરિન ક્લિયર કરી શકો છો, કોઈ તમે ખાસ દવાઓ લો છો, અને દિવસમાં તમે કેટલું પાણી પીઓ છો કે કેટલું ફ્લુઇડ લો છો, અને એમાં કોઈ આલ્કોહોલ લો છો કે કેફિનેટેડ ડ્રિંક્સ કેટલા લો છો, આ બધા સવાલ તમારા ડોક્ટર તમને પૂછશે. હવે એની સારવાર, મૂત્રાશયની નબળાઈની સારવાર, હવે આપણે કહ્યું કે લાઇફસ્ટાઇલ ચેન્જીસ અને એ કેટલું જરૂરી છે કે અમુક વસ્તુ આપણે ચેન્જ કરીએ તો એનાથી તરત જ આમાં ફરક પડી શકે છે. અને બીજું છે પેલ્વિક ફ્લોર મસલ ટ્રેનિંગ, જેની આપણે થોડીક વાત કરશું, અને બ્લેડર ટ્રેનિંગ, એટલે કે મૂત્રાશયને પણ ટ્રેન કરી શકાય. તો એને મૂત્રાશયને ટ્રેન કરવા માટે જસ્ટ સિમ્પલ થિંગ ઇઝ ટુ કીપ અ ડાયરી. હવે ડાયરીમાં કેટલું પાણી તમે દિવસમાં લો છો એનું બરાબર રેકોર્ડ રાખવાનો, 1 અઠવાડિયા માટે કે 10 દિવસ માટે આ ડાયરી બનાવવાની. કઈ જાતનું ફ્લુઇડ કે પ્રવાહી તમે લો છો, ટી, કોફી, સોફ્ટ ડ્રિંક્સ કે વાઇન, આલ્કોહોલ, કંઈ પણ લીધું હોય એનું પૂરેપૂરો રેકોર્ડ એ ડાયરીમાં રાખવાનો, અને કયા ટાઈમે કેટલી વાર તમારે દિવસમાં યુરિન પાસ કરવા જવું પડે છે, કેટલું યુરિન પાસ કર્યું છે, એના માટે તમે થોડું મેજર પણ કરીને જો અઠવાડિયું કે 10 દિવસ કરી શકો તો દેટ વુડ બી અ વેરી ગુડ ઇન્ફોર્મેશન ફોર યોર જીપી. અને જો તમને લીક થયું હોય કે થોડીક નબળાઈને કારણે થોડુંક યુરિન ટપક્યું હોય તો કેટલી વાર થયું છે દિવસમાં અને આખા અઠવાડિયામાં, અને ક્યારે તમને સ્ટ્રોંગ અર્જ, પેલી તીવ્ર ઈચ્છા થઈ હોય જવાની અને તમારે જવું જ પડે, કેટલી વાર થયું છે. એટલે આ બધી માહિતી લઈને જો તમે તમારા ડોક્ટર પાસે જાઓ તો ડોક્ટર તમને વધારે સરસ રીતે મદદ કરી શકશે. તે ઉપરાંત ડોક્ટર તમને કોન્ટિનન્સ નર્સ પ્રેક્ટિશનરને રિફર કરી શકે, અને પેલ્વિક હેલ્થ સ્પેશિયલિસ્ટ ફિઝિયોથેરાપિસ્ટને ખાસ પેલ્વિક ફ્લોર એક્સરસાઇઝ માટે પણ રિફર કરી શકે. હવે હું ખૂબ ટૂંકમાં પેલ્વિક ફ્લોર મસલ્સ આપણે જે વાત કરી એની એક એક્સરસાઇઝની વાત તમને સમજાવીશ. આ ચિત્ર આપણે પહેલા જ જોયું, આ છે આપણો પેલ્વિક ફ્લોર, એટલે કે પેડુના સ્નાયુઓ, અને આપણા 3 જે પેસેજીસ છે, બેક પેસેજ, યુટ્રાઇન પેસેજ એટલે વજાઇના, અને બ્લેડર, એ ત્રણેય પેલ્વિક ફ્લોર દ્વારા આપણા શરીરમાં નીચે ખુલે છે. સો સિમ્પલ thing I would like all of us to do, આપણે બધા અત્યારે થોડીક પ્રેક્ટિસ કરી, find your pelvic floor muscles, how do we do it? તો આપણે અત્યારે બેઠા હશું, તમારા બંને હાથ તમારા સિટિંગ બોનની નીચે રાખો, અને you sit on your hands. Okay, so the muscles between your hands are your pelvic floor muscles. એટલે આ મસલ્સ ઇન્ટરનલ છે, અંદરના છે, બહારના નથી. એટલે જ્યારે આ મસલની એક્સરસાઇઝ કરીએ, આ સ્નાયુને આપણે ટાઈટ કરીએ ત્યારે અંદર પેટ અંદર જવાની જરૂર નથી, કે ઊંડો શ્વાસ લેવાની જરૂર નથી, કે no need to squeeze your buttocks either. It is an internal tension that we have to experience. So પહેલા એટલું સમજીએ. અને હવે એક્સરસાઇઝ માટે કેવી રીતે કરવું, તો જેમ મેં પહેલા કહ્યું, સૌથી પહેલા સ્ટાર્ટિંગ વિથ ધ બેક પેસેજ. તો try to tighten your back passage as if you want to stop passing the wind. એટલે તમને ગેસ પાસ કરવો નથી એના માટે તમે કઈ રીતે એ રોકી શકો, કઈ રીતે એ પેસેજ ટાઈટ કરો એ પહેલા પ્રયત્ન કરો. સો દેટ ઇઝ ધ બેક પાર્ટ ઓફ યોર પેલ્વિક ફ્લોર. એના પછી વજાઇનલ ટાઇટનિંગ, એટલે એને માટે just imagine a string or a thread that you're pulling up from inside your vagina. Lift it up, or imagine a blueberry just moving up your vagina and lift up and hold. So that is your step 2 to feel the pelvic floor. And then comes step 3, which is your urinary passage. So as if you want to go to the toilet, but there is no toilet around, so you're going to tighten and close those muscles. So it's literally back to front. Back passage tight karvo, that's your vaginal tightening, followed by the urinary passage tightening. So back to front, basement, ground floor, first floor. Lift up and hold. That is a pelvic floor contraction. અને એમાં સિટિંગ બોન્સ નીચે કોઈ જ પ્રેશર નથી તમારે ઊંડો શ્વાસ લેવાની જરૂર કે પેટને અંદર દબાવવાની જરૂર. So that's how you would do your pelvic floor simple contraction. So આના વિશે ઘણી માહિતી YouTube અને બીજી લિંક્સમાં છે. આપણે ખૂબ જ ટૂંકમાં અહીંયા સમજાવ્યું છે, પણ તમને રિસોર્સિસમાં મળશે. તમે પૂરેપૂરો જો વિડીયો જોશો તો તમને પૂરો સરસ ખ્યાલ આવશે કે આ મસલ્સને કઈ રીતે કોન્ટ્રાક્ટ કરવા. એટલે યુરિનરી ઇન્કોન્ટિનન્સ, મૂત્રાશયની નબળાઈની આપણે જે અત્યારે ટૂંકમાં વાત કરી, ઇટ ઇઝ ટ્રીટેબલ અને ઇવન ક્યોરેબલ થ્રુ એક્સરસાઇઝ, ચેન્જિંગ ડાયટ, મેડિકેશન. તે ઉપરાંત અમુક ડિવાઇસીસ, એટલે અમુક એવા સાધનો પણ હોય છે જેનાથી આ મસલ્સને આપણે ધીરે ધીરે સ્ટ્રોંગ બનાવી શકીએ. અને ઓફકોર્સ સર્જરી પણ એક ઓપ્શન છે, પણ હું એક વસ્તુ ખાસ કહીશ કે તમે બીજું કશું કોઈ પણ ઓપ્શન આના માટે લો, પણ એક્સરસાઇઝ ઇઝ અ મસ્ટ. અને એક્સરસાઇઝ માટે આપણે એમ કહી શકીએ કે એક્સરસાઇઝ વર્ક્સ વેન યુ વર્ક એટ ઇટ. એટલે એક્સરસાઇઝ કરવાથી જ ધીરે ધીરે ફાયદો થશે, ધીરજ રાખીને ચાલુ રાખવી પડે. ટ્રીટમેન્ટ કઈ લેવી એ ટાઈપ ઓફ ઇન્કોન્ટિનન્સ, આપણે જે 3 ઇન્કોન્ટિનન્સની વાત કરી એના પર નિર્ધારિત છે, અને કન્ડિશન. પેલ્વિક ફ્લોર એક્સરસાઇઝથી સ્ટ્રેસ ઇન્કોન્ટિનન્સમાં ખૂબ જ ફાયદો થઈ શકે છે અને આપણે બધા જ કરી શકીએ છીએ. Urge incontinence may be treated with behavioral modification. અને what does that mean, behavioral modification? એટલે જ્યારે તમને જે urge થાય કે જવું છે, ત્યારે સૌથી પહેલા work on your pelvic floor and then try to clear that idea from your mind કે હમણાં હું નહીં જાઉં. Once your pelvic floor muscles are tight, you cannot leak. Tighten the muscles and just let that thought pass through for a few seconds and the urge will calm down. એટલે આ રીતની behavioral therapy ધીરે ધીરે કરવાથી પણ એમાં ફરક પડી શકે છે. અને ઓવરફ્લો ઇન્કોન્ટિનન્સ હોય, પુરુષોમાં જો એનલાર્જ પ્રોસ્ટેટ હોય તો માં ખાસ અમુક મેડિકેશન પણ હોય છે, એનાથી મસલ્સને રિલેક્સ કરી શકાય અને બ્લેડર પૂરેપૂરું એમ્પ્ટી થઈ શકે છે. રિસોર્સિસ આપણે પછી લિસ્ટમાં આપેલા જ છે, જે તમે જોઈ શકશો અને વધારે માહિતી મેળવી શકશો. અને ક્વેશ્ચન એન્ડ આન્સર સેશનમાં તમારે કોઈ પણ પ્રશ્નો પૂછવા હોય તો પ્લીઝ ડુ ગો હેડ એન્ડ આસ્ક. તમારા સમય માટે આભાર અને પ્રણામ. અને હવે હું ખ્યાતિબેનને ફરીથી વિનંતી કરીશ કે કેન્સર ટ્રેનિંગની વાત, હવે કેન્સર સ્ક્રીનિંગ રાધર, આઈ મીન ટુ પેલ્વિક ફ્લોર ટ્રેનિંગ, કેન્સર સ્ક્રીનિંગની વાત આગળ વધારે. થેન્ક યુ વેરી મચ.
That's brilliant. Sushma Ben, thank you. તમારો બહુ આભાર. I'm sure બધાને એમ લાગશે કે તમે એકદમ ફાઇન સરસ ગુજરાતીમાં સિમ્પલ રીતે આ સમજાવ્યું છે. જે બધા અમારી સાથે અત્યારના સાંભળે છે આપણું ડિસ્કશન, તમારી પાસે કોઈ બી ક્વેશ્ચન્સ હોય તો તમે 3 રીતે પૂછી શકો છો. અમારી એક લિંક છે જેમાં તમે એનોનિમસલી ક્વેશ્ચન્સ પોસ્ટ કરી શકો. તમને જો ચેટમાં ન મૂકવું હોય તો તમે આ રીતે લિંકમાં મૂકી શકો છો, એટલે કોઈ બીજાને ખબર ના પડે કે કોણ ક્વેશ્ચન્સ પૂછે છે. બીજી રીતે તમારે ચેટમાં લખવું હોય તો અમે આ બધા ક્વેશ્ચન્સ છેલ્લે આન્સર કરશું ગુજરાતી અને ઇંગ્લિશમાં. અને થર્ડ વે ઇઝ કે જો તમારે કાંઈ ટાઈપ ન કરવું હોય તો આપણા Q&A સેશનમાં અમે ઝૂમ પર કહેશું તમને કે તમે હાથ ઝૂમ પર ઊંચો કરો અને તમે વિડીયો પર આવી અને તમારો ક્વેશ્ચન તમે પોતે પૂછી શકો છો. એટલે આ હવે છેલ્લો ભાગ છે અમારા ડિસ્કશનનો, અને પછી આપણે ક્વેશ્ચન એન્ડ આન્સર ચાલુ કરશું. આ છેલ્લા ભાગમાં મારે કેન્સર સ્ક્રીનિંગની વાત કરવી છે. આ હું મોસ્ટલી ઇંગ્લિશમાં કરીશ, પણ ગુજરાતીમાં તમારે કાંઈ બી સમજવું હોય તો પ્લીઝ પૂછજો. કેન્સર સ્ક્રીનિંગ એટલે શું? So firstly, what is cancer screening? Cancer screening is a way of doing tests to pick up cancers before they progress or before they develop into something serious. A screening is done every few years to try and detect cancers before you might present with any symptoms. So the first type of screening I want to talk to everybody about is breast screening. Breast cancer is the commonest cancer in the UK. And we know that screening uptake is lower in Indian women than Caucasian or white women. We know that breast cancer screening program reduces the risk of dying from breast cancer by 20%. And we also know that 1 in 8 of us women who are listening here today will develop breast cancer at some point in their life. Therefore, breast screening is so important and it should not be ignored under any circumstance. Breast screening is for anyone registered with a GP between the ages of 50 and 71. You will get an invitation posted to you, and this will happen every 3 years. That if you have not got your invitation in the post, or you have missed your invitation, then please contact your local breast screening service to ask for another appointment. When you go to the breast screening appointment, what will happen is you will have a scan. A scan mammogram kahiye chhe. You will have a mammogram where they will take a photo of your breast from the front and from the side. This test is not painful, anathi dukhavo na thai, but it can be a bit uncomfortable. Thodu daban jevu lagse. After that, the results will be posted to you and the GP. If they find anything that needs further investigation, don't panic. Badhu je mammogram ma iloka pick up kare is not abnormal, is not cancer, but it might need investigating further. And the further investigation will be with an examination at the breast clinic, possibly an ultrasound scan and a biopsy. We know that breast screening saves lives. So it's really important. If you have ignored it, if you have not been, and if you're over the age of 50, please go. Anyone who's listening, encourage your mums, your sisters, your daughters, your friends. Make sure that everyone attends. The second type of screening that I want to talk about is cervical screening. Cervix cervix is the entrance to your womb. Okay, when we want to check your cervix, we have to examine you with this plastic instrument called a speculum. A speculum ame niche thi examine kariye. એટલે we insert it inside the vagina, and when we open it slightly, at the back of the vagina, we see this. Abija picture ma dikhai chhe, that's the cervix. The middle bit is the opening of the cervix, and that's the entrance to the womb. So you will have a little brush that takes some cells from that area to check for any changes related to cervical cancer. Cervical cancer kills around 852 women in the UK each year, and it's largely preventable. The screening for in the cervical smear actually doesn't look for cancer, but it looks for a virus called HPV, human papilloma virus. And this is found in about 99% of cancers. We know that cervical screening in South Asian women over the age of cervical cancer in South Asian women over the age of 65 is twice as high as white women. And we know that fewer Asian women attend cervical screening, which is why it's so important for us to talk about it today. It's offered every 3 years to women between the age of 25 and 49. And it's offered every 5 years to women between the age of 50 and 64. With some recent changes in research and the vaccination, this might change how often we have the smear tests. Again, the smear test can be uncomfortable, but you have to do it once every few years, and it can be the difference between detecting a cancer early that's treatable or having to go through very difficult cancer treatment. when you have the smear done, if they find the virus, the HPV virus, then some cells are looked at to see if there is a sign of cancer. And a further test called a colposcopy might be needed, which looks at the cells in more close detail. However, if you get a positive test that says you have HPV, again, don't panic. About 80% of the population at some point have the HPV virus. It's very common. And in most women, the HPV virus will not cause any long-term harm because your immune system can clear it by itself. So we also know that there is no effective cure for the HPV vaccination infection, but there is a vaccination that's being offered to younger people. So you may have daughters at school or young female family members at school who may be offered this, and it's really important to know and learn about it, learn all the facts, get comfortable and obtain this. And the last cancer screening test that I want to talk about is for bowel screening. Bowel એટલે તમારો પેટ ની જગ્યા. Bowel screening is for colorectal or bowel cancer. This is the 4th commonest cancer in the UK. And we know that 1 in 19 of the women sitting here today will develop one bowel cancer in their lifetime. The cancer survival for bowel cancer is sadly much lower than the rest of Europe in this country. And this is partly because we catch it at a much later stage. This is why screening is really important to try and catch signs of bowel cancer early. Bowel cancer screening is offered every 2 years. And people can also ask for a screening test by calling a central number, which I've left here. Again, if you get a positive screening test, don't panic. It doesn't necessarily mean that you have cancer. It means that there is some blood that has been found in your test. And this will need further investigation because there are several things that can cause this. But a colonoscopy, which is a camera test, which is done from the back passage, it's a thin tube that is inserted to look at the intestines to look for signs of bowel cancer may be needed. Again, this test can be uncomfortable, but you may be given some medicine to sedate you to make it more bearable. The actual bowel screening test comes in a kit like this. And in the kit, there is a little bottle. In the bottle, you have to obtain a sample of your poo, of your stool, put it in and send it off. Some people might not find this comfortable doing this, but it is not painful. You can wear gloves and you have to do it once. And again, it can be the difference between picking up something early or too late. We know that screening is important. I've told you today how it saves lives. So please do not ignore your invitation. And if you know that other friends and family members haven't been for their cervical screening, their breast screening, their bowel screening, please talk about it. Please encourage them to go. The other big thing to mention is that no screening test is 100% accurate. So if you have any symptoms at all of breast cancer, bowel cancer, cervical cancer, do not wait for your screening test and do not be reassured by a recent normal screening test. Please go to your doctor and get this checked out. And the final thing to say is that we're incredibly privileged that all of this is free. You don't have to pay for it. You just have to turn up. You have the responsibility to yourself, to your family, to get this done, because it does mean the difference between life and death in many cases. Thank you very much. So that brings us to the end of our discussions from our end, and we're going to be going over to the question and answer session. So as I said, please get ready with your questions on Zoom. You can raise your hands and we will come to you. We have collected your questions that have been in the YouTube and the Zoom chat, and I will pose this to the panel one by one. We'll attempt to answer in English and Gujarati. And whilst you're all getting ready, I would just like to mention our next event that is coming up. Our next event is on Sunday, the 20th of March at 8 p.m. And it's directed to anyone who is a carer. If you look after someone who has long-term conditions such as Parkinson's, dementia, or any other long-term conditions, please join us for this talk where we will speak about resources and support available for those who you're caring for and for the person who is doing the caring. એટલે તમે કોઈનું બી ધ્યાન રાખતા હોય, જેને long term conditions હોય, જેને આવી તકલીફ હોય, Parkinson's કે dementia, તો તમારા માટે આ સાંભળવાનું જરૂરી છે, કેમ કે જેટલો support અને resources જેટલા છે, એની અમે બધી વાત કરશું તમારી સાથે. So now I'm going to move on to our Q&A session. So, પહેલો questions છે સુનીતાબેન. સુનીતાબેન, આપણને question આવ્યો છે કે with everything that you've been through, with the journey that you have described to us through your infertility and the other difficulties you went through, did you find that these issues were more prevalent in Indians? And did you find that the support system was sensitive to cultural matters, to our culture? So that's to Sunita-ben.
So you've got to realize that obviously this happened to me years ago. And, you know, when I attended the NHS for the 5 years for all the investigations, I suppose proportionally, there were less Asian women than of any other kind. And that could be something to do with culture because, you know, we tried to keep our family problems to our chest. You know, whatever we're going through, we really don't want the whole world and its army to know about it. So in my experience at that time, yes, there were less Asian women going through it, going to the clinics for advice. And yes, it was definitely not talked about. And I made sure that I talked about it. Everybody knew how I had my children and what I'd had to go through. So unfortunately, I don't know what the picture is today, but I'm sure it hasn't changed much over the years.
Thank you very much. Thank you for describing your experience. I can see in the Zoom chat, Shilpa Ben has raised her hand. I'm going to come to you in a moment, Shilpa Ben. If you can, turn on your video and we'll ask you to unmute shortly. And whilst you get ready to ask your question, I will just ask one more question to Sushma Ben. Sushma Ben, you've described to us about the exercises you can do for your pelvic floor. The question from the group is, ke aa exercises કેટલા time માટે કરવી જોઈએ આપણે અને is there a way to progress with the exercises? Another question which is similar that has been asks, is stopping urine in the midstream a good way to exercise the pelvic floor muscles? So શું exercises કરવી જોઈએ અને કેટલા time માટે, please?
Thank you, Kathy. તો pelvic floor exercise જેમ આપણે આગળ જોયું એમ ત્રણ back to front જેમ વાત કરી એ રીતે એક contraction અને જે પ્રમાણે તમારા સ્નાયુની નબળાઈ હોય એ પ્રમાણે તમે કદાચ 2 કે 3 સેકન્ડ કે 4 સેકન્ડ જ હોલ્ડ કરી શકો. So that is just one slow contraction or a slow pull. અને બે પ્રકારની કસરત હોય છે, એક આ slow pull અને બીજું contraction એટલે કે muscle tightening એ જ રીતે કરવાનું પણ તરત છોડી દેવાનું હોલ્ડ કર્યા વગર. એટલે ખરેખર તો તમે pelvic health specialist physiotherapist ની સલાહ લો અને એ તમને તપાસ કરી અને actual exercise prescription આપે એ વધારે જરૂરી છે કારણ કે એ તમને અંદરથી તપાસ કરી internal examination કરીને તમને exact કહી શકે કે તમારા સ્નાયુ કેટલા નબળા છે કે કેટલા strong છે અને એ પ્રમાણે precise prescription આપી શકે. પણ ત્યાં સુધી જે રીતે આપણે કહ્યું એ રીતે muscle tight કરી hold કરવા, hold બરાબર 2, 3, 4 સેકન્ડ સુધી થઈ શકે તો અને એવું 10 repetition કરવાના અને દિવસમાં 4 થી 5 વાર કરવા. એ જ રીતે ટાઈટ immediate contraction and release એટલે fast contraction પણ એવા 10 contraction 10 repetitions દિવસમાં 4 થી 5 વાર કરવા. શરૂઆત આ રીતે કરવાની અને it takes time. It's not a fast cure but it works. એટલે ધીરજ રાખીને with patience, if you work with these exercises you can see the difference within 6 to 12 weeks, muscle weakness matters. So that's one. The second part of the question was about stopping the urine midstream. Now, that is just a test to see if you can do it or not. If you're trying to pass urine and if you stop midstream and if you can't do it, that means you know that your muscles are weak, but that is certainly not the way to exercise. એટલે એ જે misconception છે એમાંથી આપણે બહાર આવવાનું છે. એ રીતે exercise કરવાની નથી. It can even cause more problems. So that is just a way to learn about the weakness, but not really to do the exercise. Thank you.
Brilliant. Thank you so much, Sushma Bin. Shilpa Bin, I can see you're on video. Please unmute and do ask your question. Thank you so much for coming on today.
Good evening, ladies. First of all, thank you so much for presenting such informative talks and taking some of the taboo out of what can be quite difficult subjects. So thank you very much. My question is around the cancer screening and in particular cervical screening, cervical cancer screening. The information talked about being in a program that, as you say, we are so lucky to be in up to the age of 64. What are the recommendations beyond that age? Is it because the likelihood of occurrence is very, very low that screening is not necessary? And secondly, we talked about even though you may have screening and the results have come back as healthy, what sort of symptoms might you experience if you have any of the 3 forms of cancer that were covered, please?
Yeah, great question. So I'll answer some of these. With regards to cervical cancer beyond the age of 64, there isn't a screening program as such. So if there are any concerns during your final smear test before the age of 64, then you will be tested again. So if your last smear test was abnormal, you will continue to have screening until there is satisfaction. Beyond that, if there are certain symptoms that are concerning, you will have a smear test, or the equivalent may be a colposcopy rather than a smear test itself. So the question was, what kind of symptoms to look out for? For breast cancer, the one that we commonly know about is breast lumps. Okay, so if you feel a lump in your breast, and even the breast tissue goes underneath your arm as well. If you feel any lumps that are persistent, lasting more than 1 or 2 weeks, then you should go and see the GP for an examination. The less common symptoms people know about is discharge from the nipple, also the skin changes around your breast as well. And any asymmetry in the breast, if one side looks very different to the other, and that's new. For cervical cancer, any abnormal bleeding is something that you should highlight to the doctor. And by abnormal bleeding, I mean if you bleed after the menopause. So if your periods have stopped and then you start bleeding from the vagina, you need to go and see the doctor. If you bleed after sex, that's not normal and that needs investigating. And if you bleed in between your regular periods, so if you know that you have a monthly cycle, but you're bleeding in between that is a reason to go and see the GP for an examination. And for bowel cancer, some of the symptoms include weight loss, and anemia, so low iron levels or hemoglobin levels that we can't explain, and change in your bowel habit. Toiletni habit and you're having more diarrhea, then those are reasons to go and see the GP. If it's persisting beyond 3 weeks, of course, if you've got a short-term infection, that's understandable, but if it's lasting beyond 3 weeks, these are just some of the symptoms, and but that's a whole topic on its own. So this is just a brief explanation. I hope that's okay. Thanks, Shilpa Bin. Right, the next question is for Anuja Bin. Anuja Bin, we're being asked, can you take HRT after you have gone through the menopause and your periods have stopped?
Yes, again, a great question. And thank you for asking. So yes, definitely, you can start taking HRT even after you've been through the menopause. So as I said, menopause really, you can tell that you've been through the menopause 12 months after your last period. And, to discuss with your GP. And yes, you can, if you are suffering from symptoms, then you can start the HRT even, after the menopause. Yeah, definitely.
Brilliant, thank you. Sunita Bin, the next question, I think you and I will do me from a doctor perspective and you from a patient or experience perspective. I have someone saying, Jai Jinendra, my daughter-in-law had a miscarriage after conceiving after 13 years of marriage. She was about 9 weeks pregnant and we're all very sad. They're getting on with their life, but she's tired. What help and advice can I give her? So first of all, I'm so sorry that you're all going through this. It must be incredibly difficult for the person going through it and for the larger family. From a doctor perspective, early miscarriages at around 9 weeks are incredibly common. Okay, we just don't talk about it. Sometimes we don't even realize when we've miscarried that early. And as a doctor, the first thing I would say to the patient is, it is not your fault. Lots of people, lots of women blame themselves and think about whether they can do something, they could have done something differently. And I think whether people say it or express it or not, they're often the women takes the blame or feels the blame. It is unlikely that when people miscarry at that stage that they have done anything or that they would have had any control about that at all. In terms of what you can do to help, be there to listen, be there to distract them if they need it, be there to ask them what you can do and ask them. They will be able to tell you how you can help. So that's from my perspective. Sunita Bin?
So when it happened to me, when I lost my son, obviously I was going to go back to work. And the one thing I said to my manager was, look, my life has changed. Yeah, it hasn't affected anybody else, but my life, my husband's life has changed. And I don't want people to treat me as if I'm a leper. If they want to ask, just ask. I'd much rather be frank and be able to talk about my feelings than actually just hide away and shun people away. So as soon as the question was asked, I felt that twinge. After so many years, I still felt that twinge about miscarriage. But again, just like my positive, I know you waited a long time, but the thing is, it happened. So just have faith, just have hope. That's all I can say to you. And please just talk about it to anybody who will listen. And you'll find great comfort in that. And you will find that a lot of people will come to you and say, you know what, that happened to me. That happened to me. And they'll have, you would have known them for years, but you would have never known that side of their life. So I wish you all the best.
Thank you so much, Sunita. Anujabin, the next one's for you. An audience member is asking, what are your views on HRT, firstly, and also how can you, many doctors prescribe antidepressant medications because this is confused for menopause symptoms. Why is that?
Yeah, so my views on HRT, I think HRT definitely is helpful with the symptoms of menopause, and it's the most effective treatment for some of the symptoms, such as the hot flushes and the night sweats. HRT has had a really bad press. You know, we all read in the papers. It never fails to make bad press, and we've read in the papers, about the risk of breast cancer and heart problems and things, but really, there are lots of confounding factors, to go with this as well. So, the people who were on the trial, which would say that HRT increases risk of breast cancer, didn't mention that a lot of women in that group were actually elderly women who are more at risk of having breast cancer. If HRT is absolutely fine for someone who is symptomatic, is under the age of 60, and has no contraindications to HRT, or is within 10 years of the menopause. So the younger patient who is suffering from the menopausal symptoms, should not be too worried about going on HRT. And speak to your doctor. For every year you would have a review with your doctor. So ask your doctor, is it still safe for me to carry on with HRT? If the benefits of HRT outweigh the risk, then your doctor will tell you that yes, you can carry on with it. I think beyond the age of 60, the risk of breast cancer may increase, and you may need to take a very pragmatic view about it. So if the benefits still outweigh the risk, then you may want to carry on, but have this discussion on a regular basis with your GP. The second part of the question, just remind me, Catherine.
It was about the antidepressants. So many doctors are confusing symptoms of menopause with depression and offering antidepressants. Why is that?
Yes, that is true. And antidepressants are not first line for any of the menopausal symptoms, and even for mood swings that are truly due to menopause, HRT would actually help more than antidepressants would. But many doctors have in the past. We know that antidepressants are being overprescribed for these symptoms. So if you have got symptoms of the menopause, try HRT if you haven't got any contraindications.
Brilliant, thank you. Next question is for you, Sushma Bin, and it's about prolapse. In fact, a few people have asked this question, saying that they've got a problem with the prolapse, and can this impact continence? One person is saying that they've got a problem with prolapse coming and going when they pass urine. So how do you control that? How do you control your urine if you've got a prolapse, and how do you make it better?
That's an important and can be quite a huge health issue. So yes, very pertinent question. Prolapse meaning that there is a little drop of one of the organs as your muscles may be weak. And so sometimes women feel it as if, there is when they are standing particularly, or when it's in the early stage, they feel it as if at the end of the day, they feel heaviness in the vagina, or maybe something that slightly drops, like a little plum, that kind of sensation or feeling. It can cause incontinence because of the pressure. And depending on the extent of the prolapse, the treatment is determined. If the prolapse is in the early stage, and you definitely need to see your GP, and they may refer you to the pelvic health specialist therapist who can start on a right exercise program, and that may just begin to help you if it is in the early stages. If the prolapse is quite advanced and it's really impacting your lifestyle a lot, then you may have to revert to, depending on which organ is prolapsed, whether it is just a vaginal prolapse, or whether it is sometimes it can be prolapse of your uterus, or part of it, or it can be even the bladder or the bowel prolapse. Depending on that, then the further treatment is determined. So we cannot obviously be very specific about it here. However, that I would definitely recommend a very early visit to your GP, who can then maybe refer you, if needed, to a urogynecologist, who can then test further and then recommend the right pathway of treatment. But exercise as a starting point definitely is helpful, and in a very early stage of prolapse, it is beneficial, and you may not need to go further.
Brilliant, thank you. The next question for me is, how do I check for breast lumps? Okay, this is really important because screening is every few years, and the recommendation is કે તમે પોતાનું શરીર કેવું છે ઈ જાણકારી રાખો. Learn your body, learn and understand what it feels like. So કાંઈ ખરાબ થાય, કાંઈ abnormal હોય તો તમને તરત જ ખબર પડે. we recommend every few months, every 3 to 6 months, that women check their own breasts. Tame potana breasts check karo. Ane kevitna check karwana. If you imagine ke circle hoy, તમે સર્કલ ને 4 ભાગમાં પાડો એવી રીતના તમારા બ્રેસ્ટ્સ ને 4 ભાગમાં પાડો અને તમારા હાથથી તમે દબાવી each every section, every quarter, you press firmly to see if there is anything that you feel that's a lump. Also, don't forget to feel under the nipple. And like I said, the breast tissue goes into the underarms. So don't forget to feel in the underarms as well. For those of you who have periods, your breasts change with your cycle. And it's really important that you check your breasts in the same part of your cycle. So I say to women to wait until their period is finished and then check their breasts, and do this every 3 to 6 months. It's also helpful if you're lying down. Some people prefer to do it whilst they're in the shower, but get into a regular routine of learning to check your breasts. Okay, the next question is for Anujaben. Anujaben, this is related to one of the treatments for the menopause, which you mentioned, called CBT. Can you tell us a bit more about CBT and how this helps the menopause?
Sure. So CBT, or cognitive behavioral therapy, is really a strategy to help yourself cope. So it teaches you a coping mechanism. CBT, I'll just give you an example. So CBT can be really helpful for the symptoms of the menopause, such as the hot flush. So there's a connection between the physical symptoms, what we think, what we feel, and our behavior. So say, for example, if you have a hot flush when you're in the office, your body goes really red hot. And some people actually, look really red in the face and flush in the face as well. Immediately you will think, so your physical symptoms, your thoughts, your feelings, and your behavior. So your thoughts will be, everybody can see me. My colleagues are going to notice this. And then you feel anxious and embarrassed. And your behavior would be to avoid certain situations, avoid maybe going to a meeting, avoid, socializing with your colleagues, particularly male colleagues. So this can be a very negative kind of cycle. And what CBT does is to actually help you learn how to cope with the situation and help you cope with it better. So this is just an example. So, when you're doing CBT, you think, you've got a hot flush. You understand that it's a problem with your body's thermostat and the regulation of the heat in your body. So when you understand that it's actually a problem, then your thoughts would be, oh, it's going to go away in a while. Let me just do some deep breathing exercise, and then you feel less anxious about it, and you're not then going to be avoiding the situation. So this can help you cope with the symptoms. Similarly, CBT can also help with low moods and anxiety, which are some of the symptoms of the menopause.
Brilliant. Thank you, Anujaben. Bhadraben, I can see your hand up. So I will come to you just after our next question. Please have your camera on if you can, and you'll get a prompt to unmute shortly. So the next question is, why do women have secondary infertility after already having a child? एक बार तुम्हारी pregnancy થઈ ગઈ હોય અને છોકરું થઈ ગયું હોય તો બીજી વાર કેમ pregnant થવામાં problem થાય છે? That's the question. So as you grow older, as time passes, your body changes and your health changes, and we find that there could be many reasons after, if you've had a child, that you may not be able to conceive again. Some of the causes are the same as primary infertility. So there may be a change to your medical history, developing additional medical conditions such as thyroid problems or other gynecological problems. You may have had surgery or complications from the first birth that might cause a problem with the subsequent pregnancy. You may be a little bit older for your next pregnancy, which reduces the risk of conceiving as well. So there, as your body changes, your health risk and your fertility changes with that as well. You may be on some new medications which might interact and interfere with that. So if you are having problems with your second child, you can still ask for fertility help as well. It's not just for the first child or the first pregnancy. So do go to your GP, and actually a lot of the things we will do will be exactly the same. Tests for men, tests for women, even referral to the fertility clinic to help you with a second pregnancy or discuss your options if needed.
Thank you.
Okay, Bhadraben, over to you. Tamara question hato?
I just wanted to say, you say that examine your breast, but sometimes nodular breasts could give you a feeling that you actually have a lump. And that has happened, so I just wanted to make that point, so make women aware of that as well.
That's such a good point. Thank you so much for raising that. And this is why I was saying that it's really important to know your body. Lots of people just have lumpy breast tissue, and that's completely normal. When you feel it, thodu lump jo lage, pan ghani badi jagyaye hoy ke har mahine same j hoye itna. Once you know your body, you will see ke kaik nawu chhe, kaik alag chhe. And that's what needs to prompt you to go to the doctor. So thank you so much for raising that.
અને બીજું મારે એ પૂછવું હતું કે મોટી ઉંમરના માટે કેટલું જરૂરી છે આ સ્ક્રીનિંગ, કેન્સર સ્ક્રીનિંગ?
So મોટી ઉંમર માટે screening tests જે ઈ લોકો age range આપે છે, it's really important that all through those age ranges you go. So you'll see that bowel screening is up to the age of 74. So and the reason they do that is because of how common those cancers are in those age groups. એ પ્રમાણે લોકોએ screening ની ages રાખી છે. એટલે screening જેને બી offer આવે ઈ તરત જ લઈ લો, અને બંધ થઈ જાય screening ની age પછી તમારો screening બંધ થઈ જાય, એની પછી તમે symptoms નું ધ્યાન રાખો. Symptoms બદલાય તમારા, જેની મેં વાત કરી હતી, એનું ધ્યાન રાખો અને ઈ તરત લઈ જઈ અને ડોક્ટર સાથે વાત કરો.
Okay, thanks. Yeah.
Thank you. Next question, we've got a few more and we're coming to the end. So I'm going to ask just a few more that are left. So another one for Sushma Bin. Sushma Bin, there's one around urethral dilatation, and you may or may not be able to answer this, but let us know what you think. So it says, can urethral dilatation help with urge and overflow incontinence? And are there risks related to this procedure?
Kathy, I'd rather you answer that question.
Yes, I'm more than happy to answer it. Yes, so urethral dilatation, Sushma Bin explained that you have the bladder and then you have a little tube that brings urine out from the bladder externally. Sometimes that tube can become narrow, patlu thai jaye, sakru thai jaye, and that can happen because you've had lots of infections or some people are born that way. So if that tube becomes very narrow, there is a procedure where the surgeons can make stretch that tube and make it wider. And this is a well-known treatment for a certain type of problem. And it can work, but as with any surgical procedure, there is always a risk. There's always a risk that it doesn't work. There's always a risk that that can cause a little bit of additional damage. But if they have offered this procedure for you, then it's worth talking to the people who will do the procedure. They will go through your specific risks and the specific benefits to you as well. Is there anything further you want to add to that, Sushma Bin?
No, that's fine. Thank you.
Okay. The next question, back to Anuja Bin, is that a member is asking that they've read that HRT is going to soon be available from chemists. Will we still need a GP prescription for it?
Yeah, that's true. And there is talk about HRT being available over the counter. And no, you won't need a prescription if it is available over the counter. I think there is talk about that, yes.
Brilliant, thank you. The next one is for Sushma Bin and Anuja Bin. There are members of the audience asking, how early can this problem start? So for incontinence and for menopause. Start with Sushma Bin.
You go first, yeah.
So incontinence, like we said earlier, can start at any stage much earlier. It can be in your 20s. And like I said, pregnancy and childbirth are one of the causes, but not necessarily. And there can be just pelvic floor muscle weakness, which can start. So it can start very early, and it can be very effectively treated. We've seen cases where, women are very much into exercise, which is great. But sometimes when you've overdone it and you've lifted heavy weights and things that itself are too heavy for your body frame and for your size, and a sudden exertion can lead to pressure and weakness that can then develop. Occasionally, it can lead to even prolapse. So that it can start at any time. And it can be effectively treated if it is identified early, and if it is known that it's stress due to the pelvic floor muscle weakness. So that's that part of question. Sorry, can you remind me of the other part?
How early? No, it was just how early can the problem start, just for menopause and for continence.
So Anuja can respond to the menopause part.
Yeah.
Thank you.
So in terms of menopause, during the perimenopausal period, women notice that their pelvic floor is getting weaker, and it's mainly due to loss of elasticity of the tissues around the pelvic floor and the bladder, and this tends to actually stay with us until we're a lot older. And actually, many elderly women have recurrent urine infections for this reason as well, because of the lack of elasticity. And also the short urethra and vaginal dryness and everything in combination, what we call vaginal atrophy. And it's actually not just the vagina, but also the urethra, the bladder, everything tends to get a bit thin, loses elasticity, and it's a lot easier for the infection to reach the bladder and cause recurrent urinary infection. So not only incontinence, but the urine problems can last for many years, and later on in life it can cause recurrent urinary infections. We say recurrent if you have had more than 3 or more infections in a year. And if you've had lots of infections, speak to your doctor and they can do something about it. Sometimes they can give you some topical HRT, so just estrogen that you apply down below, which can actually help the elasticity or improve the elasticity in your vagina and your urethra.
Brilliant, Anuja Bin, thank you. Sushma Bin, another question related to an overactive bladder. So should people who have overactive bladder stop drinking as much water?
People with overactive bladder, no. I mean, reducing the water fluid intake and itself, it can be counterproductive, and it can irritate the bladder more. And then, like we said previously, urine can be more concentrated. But the better thing would be to keep that diary that we talked about, and also get into bladder training, which means that go regularly to and empty the bladder as much as you can, so you're not actually dealing with a situation when there is too much of bladder accumulation and retention. So fluid intake should be maintained, but you need to be actually planning and keeping your habits, visiting the toilet regularly, so that the problem is not exaggerated.
Thank you. Badarin, I can see your hand up, so I will come to you for the last question shortly. And prior to that, one potentially for Anuja Bin and myself to do a double act on. Anuja Bin, the golden question is, what helps with sleeping?
What helps with sleeping? Honestly, it's actually a number of things, but I would say exercise is probably on top of my list. And I feel that exercise will help with everything, not just sleeping, but your night sweats, your moods, and everything. Obviously, having a good sleep hygiene, so making sure that you're not having too much caffeine too late in the evening. And I think we these days, we tend to go to bed with our phones or our laptops or our iPads. So I think we need to make sure that we're not using these too late at night. The blue light from the screen seems to affect our sleep. So wind down, maybe a milky drink, and having a relaxing bath or listening to relaxing music, making sure that we're not stimulating our brains too late will help. And our bedroom should only be for sleep. So, try and not take work. We've all got into a habit of working on our laptops, especially working from home. So we're all working till late. So make sure that we're not working and keeping our brain active. For me, if I'm too stressed, or I'm thinking of lots of things, writing a list down helps. So I can make a list of things. So I'm not thinking about it all the time at night. So that seems to help.
Brilliant, thank you. The only additional thing I would add is if you are going through the menopause and you're suffering with hot flushes, it can be really problematic for sleep. So light kapda, cotton na kapda, just a small fan or having a window open can be really helpful with those sorts of symptoms. Tame doctor પાસે જશો અને કહેશો કે તમને સુવાનો પ્રોબ્લેમ થાય છે, તો એ લોકો પહેલા તમને દવા નહીં આપે. પહેલા અમે બધું આજે અનુજાબેને ડિસ્ક્રાઇબ કર્યું છે એ તમને ટ્રાય કરવાનું કહેશું, કેમ કે દવા જે સુવા માટે હોય એ ક્વાઇટ એડિક્ટિવ હોય. તમે લેશો તો પછી એ છોડી નહીં શકો બહુ ઇઝીલી. અને પ્રોબ્લેમ વિથ સ્લીપ ઇઝ નોટ a problem, it's a symptom. તમને ઊંઘ ના આવતી હોય તો એનું કંઈક રીઝન છે. એટલે તમને સુવાની દવા આપવાના પહેલા અમને એ જાણકારી કરવી છે કે પ્રોબ્લેમ શું છે. It's not as simple as taking a medication to go to sleep. Bhadraben, back to you.
Yeah, I must congratulate Sunita Ben that despite the fact that she had a still childbirth, she was quite positive throughout and, sort of even mentioned it to the manager. But what I wanted to point out was the postnatal depression is something that is not very much known among Indian women, and we don't even recognize it. સાસુએ તો ગાંડી થઈ ગઈ છે, આમ નથી કરતી, આમને ઊભી નથી થતી, બાળકને દોડાવતી નથી, આ બધા પ્રશ્નો થાય. To the extent that is it possible that you can get that feeling of even killing your newborn babies? Because I read something that a woman's first child was stillborn, and so the second one, she just couldn't bear looking at him and had that feeling of almost murdering that child. Is that sort of thing possible?
I mean, it's such a difficult area, Bhadraben, and you're right, Sunita-ben has been largely positive, but I'm sure she's gone through such a difficult period, and at the time, I'm sure there were dark moments as well. We have many patients who have very severe depression at any point, and then postnatal period makes them even more vulnerable. And certain people who don't have the right support, that don't have the right kind of support system, find it incredibly difficult. And just with anyone, a postnatal depression can have such a big spectrum. You can have it mild and you can have it incredibly severe to the point that you feel like harming yourself and your child as well. And it's so important that we catch it before then. And you're right, it is something that as Indian women, we don't talk about, we don't understand, depression generally. And so our hope is that we can talk about these topics more. And we're hoping that in the future, we can also do another webinar where we talk about things like the postnatal period so that we can bring this to light as well. But again, another really important point that you've made today. On that note, I would like to thank all the audience members for joining us, particularly our panelists today as well. And I'd like to pass it back on to Dr. Rajvi Punather to close off our webinar today.
Thank you so much to our wonderful speakers, Kathy Ben, Sushma Ben, Anuja Ben, and Sunita Ben. I think they've given a fantastic talk today. It's something that we've wanted to do for a while, is opening the lid on these taboo subjects. Don't forget, our next event is on the 20th of March. We're talking about caring for people who have long-term health conditions like Parkinson's and dementia. So please do join us. And if you go to the OneJAIN UK website, you can actually see all our previous health talks as well. So with that, I'd like to also finally thank our Zoom team, Nemish Pai and Paresh Pai, who've been working furiously behind the scenes, managing the YouTube and the Zoom. And we hope to see you all again next month. Vadane Jai Jinendra.